Hello, future nurses and science students. My name is Mr. Aorta, and I am the absolute sovereign queen of the circulatory system. I am the largest, thickest, and most heavy duty artery in the entire human body. In an adult, I am roughly the same diameter as a garden hose, measuring about 2.5 to 3 centimeters across, and I span all the way from the top of your heart down into your lower abdomen. In your advanced critical care lectures and clinical units, you will hear my structures and life-threatening emergencies described using my direct name or the root word aorto, like aortic stenosis, aortic dissection, or aortogram. If you see those terms, it's all about me. My primary mission in life is monumental. I receive every single drop of bright red, freshly oxygenated blood pumped out by the left side of the heart and distribute it through an elaborate branching network to feed every organ, tissue, and cell from the top of your patient's brain to the tips of their toes. Anatomy, the four structural segments. To pass your cardiovascular nursing exams and understand surgical blueprints, you must map out my path in the exact order that blood travels through me. I am split into four distinct geographic segments. 1. The ascending aorta. This is my starting gate, rising straight up from the roof of the heart's left ventricle. The gateway. I am separated from the heart by the aortic semilunar valve, which snaps shut after every beat to prevent blood from falling backward. The coronary roots. The very first branches coming off my base are the left and right coronary arteries. This means Mr. Heart always feeds himself fresh oxygenated blood first before sharing it with the rest of the body. 2. The aortic arch. I curve backward and over the top of the heart like an upside down U or a walking cane handles. The brain branches. This arch features three massive high-yield branch pipes that shoot straight upward to feed the head, neck, and upper limbs. One brachiocephalic artery splits to feed the right arm and right side of the brain. 2. Left common carotid artery pumps blood straight up the left side of the neck to feed the left hemisphere of the brain. 3. Left subclavian artery routes blood down the left arm. 3. The thoracic aorta descending. After the arch, I plunge straight downward through the chest cavity, running parallel to the spine and right behind the lungs, throwing off small branches to feed the esophagus, bronchi, and chest muscles. 4. The abdominal aorta. The moment I pierce through the muscular wall of the diaphragm, my name changes to the abdominal aorta. The organ feeders. I branch out beautifully into major pipelines to feed your abdominal infrastructure, the celiac trunk, stomach, liver, spleen, the superior and inferior mesenteric arteries, intestines, and the renal arteries, kidneys. The grand fork, right around the level of the belly button, L4, vertebra. I terminate by splitting into two main pathways, the left and right common iliac arteries, which route blood down into the pelvis and legs. Microanatomy, the three layers of the wall. Because I receive blood directly from the violent, high-pressure contractions of the left ventricle, I hold the highest pressure in the body. To survive this constant hammering without bursting, my wall is built like a steel-reinforced steel pipe with three distinct layers. Tunica intima, the inner silk, the innermost lining made of a single layer of perfectly smooth endothelial cells. It allows blood cells to slide past at high speeds without friction or clotting. Tunica media, the muscular elastic engine. This is my thickest and most critical layer. It is packed with smooth muscle cells and packed with dense ribbons of elastic fibers. This allows me to expand dynamically when the heart slams blood into me, systole, and then elastically recoil to keep pushing blood forward when the heart rests, diastole. Tunica adventitia/externa, the outer armor. A tough outer sheath made of woven collagen fibers that anchors me to the surrounding tissues and prevents me from overexpanding or blowing out. Common aortic pathologies, the high-yield disasters. When my structural layers peel apart or stretch thin under high pressure, catastrophic, life-threatening emergencies surface instantly. 1. Aortic aneurysm, the weakened bulge. A localized permanent dilation or ballooning out of my wall, usually caused by chronic hypertension or atherosclerosis, degrading the elastic fibers in the tunica media. Abdominal aortic aneurysm, AAA, the most common form occurring in the abdomen below the kidneys. The rupture crisis. If the ballooning wall gets too thin, it can rupture completely. Because I carry the body's main blood volume, an internal aortic rupture causes catastrophic, fatal exsanguination, bleeding out within seconds. 2. Aortic dissection, the internal tear. A medical emergency where a sharp tear occurs in the smooth inner tunica intima layer, usually driven by unmanaged high blood pressure. The pathophysiology: high pressure blood forces its way through that tear, ripping the tunica intima away from the middle tunica media layer. This creates a dangerous false lumen or secondary channel where blood pools and tears the wall apart longitudinally. The clinical presentation: the patient will scream in sudden, agonizing, excruciating pain that they will describe as a tearing or ripping sensation felt sharply in the chest or radiating straight between their shoulder blades. Critical nursing assessments and implications. The AAA palpation warning: if you are performing a physical assessment on a patient with a known or suspected abdominal aortic aneurysm, you may observe a distinct, visible, pulsating mass in the periumbilical area of the abdomen, and you may hear a turbulent swishing sound, a bruit, when listening with your stethoscope. The strict rule: never deeply palpate a pulsating abdominal mass. Pressing firmly on an aneurysm can easily rupture the fragile, paper-thin arterial wall, causing immediate internal death. The dissection pulse assessment: if you are caring for a patient with a suspected acute aortic dissection, your highest priority physical assessment is checking bilateral blood pressures and pulses. Because the tearing wall can physically flap over and block major branch arteries, you will often find a profound blood pressure discrepancy between the left and right arms, or completely absent peripheral pulses in the lower extremities. The strict blood pressure goal for any patient with a known aortic aneurysm or a recovering dissection: your top-tier pharmacology intervention is keeping their blood pressure and heart rate low using medications like beta blockers, for example, labetalol. The rationale: every time the heart beats violently, it sends a wave of high-pressure force slamming against my walls. By keeping the heart rate and blood pressure tightly controlled, often keeping systolic limits strictly between 100 to 120 millimeters of mercury, you minimize the stress on my fragile walls, preventing a deadly tear or rupture. Always document exact vital signs and pain characteristics. Follow us on YouTube, Felix K's Explore for more. Otherwise, like, share, and follow us if you enjoyed the class. Thank you for your support.